Coming to the second point, that is which type of jaundice will increase. Come to this diagram again. You can guess it for yourself. If there is damage before the liver, there is only one type of bilirubin that is present before the liver. So if there is any damage here, or if there is increased hemolysis here, definitely only this type of bilirubin will increase. So in prehepatic jaundice, only unconjugated bilirubin increases. If there is damage to the liver has both the types, conjugated as well as unconjugated. So in hepatocellular jaundice or hepatic jaundice, both unconjugated and conjugated will increase, right? And after the liver, there is only conjugated bilirubin. So in obstructive or post-hepatic jaundice, only conjugated bilirubin will increase, right? Come back to the table and let's see what the second point is. The type of bilirubin that increases in prehepatic or hemolysis is unconjugated. Very simple. In hepatic is unconjugated as well as conjugated. Both the types of bilirubin increase, and in post-hepatic or obstructive jaundice, only conjugated bilirubin will increase. It is very simple. You just need to remember the site of pathology, right? If there is increased hemolysis, you need to know that hemolysis can occur before the liver in the blood vessel, so unconjugated will increase. If there is liver damage, liver has both conjugated and unconjugated, so both will increase. If it is obstructive jaundice, that means there is obstruction to the bile flow. In the bile duct or in the biliary tree, only conjugated bilirubin is present, so only that will rise in obstructive jaundice. The remaining will be normal, right? So that is the second point. Third point is the Vandenberg test. I have explained this here for this point. Vandenberg test is indirect positive. Now what do you mean by this? We've seen in this that unconjugated bilirubin increases. Okay, so unconjugated bilirubin is insoluble bilirubin. You need to remember, unconjugated is insoluble. I don't know how do you remember it, some mnemonic or anything, but you need to get this fact that unconjugated is insoluble. And as we all know, diazo reagent does not react with insoluble bilirubin. You need a solubilizer. You need to make that insoluble bilirubin soluble, right? So we add methanol. Since diazo reagent did not give the purple color directly, but it gave a purple color on addition of methanol, we call this reaction indirect positive. Indirect positive. So if we take a serum sample and we add Vandenberg reagent or the diazo reagent and there is no purple color, and if we add methanol and then there is purple color, we say that this is indirect positive. And this is indirect positive because initially the bilirubin that was present was insoluble. The insoluble bilirubin is unconjugated, and unconjugated bilirubin is seen in prehepatic or hemolytic jaundice. Therefore, we can come to a conclusion that indirect positive test is given by or is seen in prehepatic or hemolytic jaundice. Very simple, right? So this is one reaction how Vandenberg test helps us to differentiate between the different jaundice. So indirect positive is seen in prehepatic or hemolytic. In hepatic jaundice, what occurs is biphasic reaction. As we all know that in hepatic jaundice, both unconjugated and conjugated will rise. Conjugated is soluble, unconjugated is insoluble. So the serum sample has both soluble as well as insoluble. So when you add the diazo reagent, it will react with the soluble and form purple color. But when you add methanol, the insoluble bilirubin will become soluble and the purple color formed will be intensified. This is known as biphasic, means 2 times you're getting the purple color. Initially, there is a faint purple color. On addition of methanol, the purple color intensifies, the intensity increases. So this means initially both soluble and insoluble were present, because initial purple color is due to soluble bilirubin, and on addition of methanol, increased purple color is due to insoluble bilirubin, which has now become soluble. So we can say that the sample has both conjugated and unconjugated bilirubin, and this means that the patient is suffering from hepatic or hepatocellular jaundice. So this is the biphasic reaction. Therefore, we have seen that biphasic reaction, this is biphasic reaction and is given in positive by the hepatic or hepatocellular cases. Moving on to the third type, that is direct positive. Very simple, as the name suggests, if there is a sample and if you add the diazo reagent, you will directly get a positive reaction, that a purple color, and this is seen only if soluble bilirubin is present, that is conjugated bilirubin is present, and conjugated bilirubin rises only in post-hepatic or obstructive jaundice. Okay, so this was about the different types of reaction that we get on doing the Vandenberg test. Okay, so Vandenberg test is a very important LFT, liver function test. It forms a part of the liver function test, right? Because we can find the different types of jaundice with the help of the Vandenberg reaction. Moving on to the next point, we see that urine bilirubin is absent in prehepatic jaundice. Now, why is this so? Coming back to this diagram, let me get this out of the way. You need to remember this, okay, that before the liver there is unconjugated bilirubin increased. In the liver there is both unconjugated as well as conjugated, and after the liver in the biliary tree there is presence only of conjugated bilirubin, right? So you need to remember that and you need to keep that in mind. If you keep that in mind, everything is simple. Moving on. So we said that urine bilirubin is absent in prehepatic jaundice. Now what does that mean? This means that whenever there is increased hemolysis, we are talking about prehepatic jaundice, so there is increased hemolysis. We know here that there is unconjugated bilirubin, or there is bilirubin bound with albumin. Okay, so bilirubin is bound with albumin, and this albumin bilirubin complex cannot be filtered by the kidneys, right? Since it cannot be filtered by the kidneys, it cannot be excreted into the urine. So we say that the albumin bilirubin complex is not filtered, therefore it is not excreted, therefore urine bilirubin is not seen in cases of prehepatic jaundice. In hepatic jaundice, there is unconjugated as well as conjugated, right? So if unconjugated and conjugated increase, we've seen that only conjugated is the soluble one. So the soluble one can easily pass through the kidneys and come into the urine, and the insoluble one cannot, right? So the soluble one, the conjugated bilirubin, is responsible for the presence of little amount of urine bilirubin in the case of hepatic jaundice. In the case of post-hepatic or obstructive jaundice, we've seen that there is only conjugated bilirubin present, and conjugated is a soluble type of bilirubin. Therefore, all of the raised bilirubin will pass through the liver, will pass through the kidneys, will get filtered and come into the urine. So we say that urine bilirubin is present also in the post-hepatic jaundice. Moving on to the fifth point, we say that the urine urobilinogen is increased. Now what does this mean? Again, this diagram explains everything. All the points mentioned here except for the Vandenberg test will be explained by this diagram. Also the Vandenberg test, if you remember the conjugated and unconjugated part. Okay, so we say that in prehepatic jaundice there is increased unconjugated bilirubin, right? So if there is increased unconjugated bilirubin here, this means increased amount of unconjugated bilirubin is passed into the liver. This means liver is showing increased conjugation, which means the amount of conjugated bilirubin that has been released into the intestines has increased, right? If input is more, definitely the output will be more. If more amount of conjugated bilirubin is coming into the intestines, more breakdown will occur, more urobilinogen will be formed, and more urobilinogen will be excreted. Very simple. Therefore, we say that the urine urobilinogen increases. Why? Because there is increased input of unconjugated bilirubin, there is increased output of conjugated bilirubin, there is increased breakdown of bilirubin, therefore increased synthesis or production of urobilinogen, therefore increased excretion. Alright, it's logical, it's very simple. Now coming to hepatic jaundice. Now what happens here is that we know that urobilinogen is formed in the intestines. We've already seen that, right, in the mechanisms. But for the bile to reach the intestines, it should be conjugated. Now if the machine leading to conjugation, that is liver itself, is damaged, do you think there will be conjugation? Do you think the level of conjugation will be normal? No, there is damage to the hepatocytes, therefore conjugation fails. If conjugation fails, the amount of conjugated bilirubin released will decrease, will go below normal. If the amount of bilirubin reaching the intestines is below normal, the amount of bilirubin broken down into urobilinogen will decrease. Therefore, the excretion will decrease. Urinary excretion of urobilinogen in cases of hepatic or hepatocellular jaundice decreases. Same is the case with obstructive jaundice. Now the input is normal, the machinery is normal, but the output has been blocked. So do you think enough or adequate amount of bilirubin will reach the intestines? No. Therefore, the amount of urobilinogen formed will also reduce. Right? So therefore, we say the amount of urobilinogen is reduced to a great extent or even absent. Because when liver is damaged, entire liver is not damaged. Some part is still functional. Therefore, some conjugation occurs and some amount of bilirubin has been reaching into the intestine and some amount of urobilinogen has been formed, but that amount is below normal. Therefore, in hepatic we say it is reduced. But in obstructive jaundice there is obstruction. There is total blockage. Almost no bilirubin can pass and reach the intestines. Therefore, the amount of urobilinogen formed is almost zero. Therefore, urinary excretion is almost absent. Therefore, we say that amount of urinary urobilinogen in post-hepatic or obstructive jaundice is very, very low or even absent. Okay, moving on to the next point, that is fecal stercobilinogen. It is the same concept as urobilinogen: increased input, increased conversion and increased output. So stercobilinogen is excreted via the feces, right? It is the same concept throughout. The concept of urobilinogen, right? Even if we see here, there is problem with the machinery, problem with the conjugation center, but some of the hepatocytes are still normal and functional. So some amount of stercobilinogen will be formed and will be excreted in the feces. Now, as we all know, stercobilinogen is converted to stercobilin, which gives color to the feces. Here the amount of stercobilin is reduced, therefore there will be pale colored stools. Okay, and in obstructive jaundice we've seen that urobilinogen is almost absent. Same is the case of stercobilinogen, almost absent. Stercobilin is almost absent, therefore there is clay colored stools or white stools is seen in obstructive jaundice, right? Okay, moving on to fecal fat level. Now you will study in digestion and absorption of fat that bilirubin is necessary, it is important for absorption of fat. Bilirubin or bile acids should be present in the intestines, right? Absorption of fat takes place from the intestines. It requires bile salts, okay? So in hepatic jaundice we've seen there is increased input and increased output. So there is increased levels of bilirubin and bile salts in the intestine, therefore fat absorption will increase. If the fat is absorbed, the amount of fat excreted will be reduced, therefore fecal fat level will be reduced or normal. Here we are not saying reduced because the amount of fat that has been absorbed and excreted, it remains normal. The absorption depends on the bile acid and bilirubin, the excretion remains normal. Right? So we say that is reduced or almost normal fecal fat content. But here in hepatic and post-hepatic jaundice, where there is reduced levels of bile acids and bilirubin present in the intestines, do you think the fats will be absorbed properly? Fat absorption requires bile acids. If bile acids are deficient, if bile is not coming, do you think the fats will be absorbed? No. If they are not absorbed, they will be excreted via the feces. So fecal fat level will be increased here. Right? It's very simple because here the amount of bile reaching the intestines has reduced. Right? So bilirubin, bile salts, all the things present in the intestines will be reduced. Fat absorption will reduce and fat excretion will increase. Now coming on to the investigations, these last 3 points are basic investigations that are to be done when the case of jaundice appears. So differentiate. Now one investigation is the Vandenberg test also, right? But other investigations are blood smear. If you prepare a blood smear, you will see hemolyzed RBCs, right? They are broken RBCs. RBCs membranes are ruptured. So hemolyzed RBCs, if you see, there's only one case, that is hemolytic jaundice. I'm talking about jaundice strictly, okay? If you see a blood smear showing hemolysis, then it is a case of hemolytic jaundice. Whereas in hepatic and post-hepatic jaundice, the blood smears will be normal, the RBCs will be absolutely normal, there is no hemolysis. The albumin globulin ratio. Now you will study in detail about the albumin globulin ratio again in biochem, but just to give you a brief idea that albumin is synthesized in the liver mainly, and whenever there is liver damage, the albumin levels fall. Normally amount of albumin is more than globulin, so albumin globulin ratio is more than 1. Okay, whenever there is liver damage, albumin synthesis reduces, so the levels of albumin will reduce, therefore this ratio will fall. We are talking about hepatic damage, right? So you get an indication where this ratio will change in hepatic jaundice. Let's see. So albumin globulin ratio here will be normal, obviously, because the liver is normal. Here the liver is damaged, so the albumin globulin ratio will decrease. Obviously, albumin is the numerator. So if the numerator decreases and the denominator is constant, the overall ratio decreases, right? So albumin globulin ratio will decrease. Here again, the liver is normal, so you get a normal albumin globulin ratio. Third investigation you do is the serum alkaline phosphatase levels. Now, alkaline phosphatase is a serum enzyme that is raised in various conditions, okay? But here specifically it is raised in a particular type of jaundice. Let's see which. In prehepatic or hemolytic jaundice, it is normal. In hepatic jaundice, it is slightly increased. In post-hepatic or obstructive jaundice, it is markedly increased. It is increased to very high levels. Now, why is this so? Now, you need to know that serum alkaline phosphatase is present in various tissues. Alright, it is present in small amounts in the liver, whereas it is present in very high amounts in the biliary tree. Now the concept of raised enzyme levels is this: wherever the enzyme activity is seen, if that site or that organ is damaged, the amount of enzymes leaking from that organ into the blood will increase, so the enzyme level will increase. Therefore, we can diagnose or we can detect various conditions based on the enzyme levels. We have designated specific organs to have specific enzymes. In this case, we see that liver has small amount of ALP, alkaline phosphatase, but biliary tree has large amounts of alkaline phosphatases, right? So whenever there is liver damage, small increase will be seen, but whenever there is biliary tree damage, as in obstructive jaundice, large increase will be seen. Therefore, we say that alkaline phosphatase levels, if they are markedly increased more than normal, like huge increase, it is obstructive jaundice. If you really want to know the normal levels of alkaline phosphatase, then they are about 3 to 13 and the units are Ka, King Armstrong units. These are the normal levels of alkaline phosphatase, 3 to 13 King Armstrong units, right? So that is all about the different types of jaundice. Most of these points can be covered by a simple diagram, that is this. All you need to do is to remember that before the liver there is unconjugated, in the liver there is both, and after the liver there is conjugated bilirubin, and that will explain most of the points here. You don't need to learn anything, you just need to understand and try to remember as much as you can. Vandenberg test, I've explained it to you the best I can, and I've tried to put everything into this table in a tabular format. This is all you need for your physiology examination. Alright guys, moving on to the last topic, that is the concept of neonatal jaundice. Now what happens is that when a baby is born, for the initial 2 to 5 days after the baby is born, for about say 2 to 5 days, the baby shows jaundice, and this is normal, therefore known as physiological jaundice. Neonatal jaundice is also known as physiological jaundice. Neonate means a newborn. Alright. So this is seen normally. It occurs because of two reasons. Number one, there is increased RBC destruction. When a newborn is born, there is increased levels of RBCs there, right? So they get destroyed in large numbers. This leads to increased production of bilirubin, leading to jaundice. The second point is that there is hepatic immaturity. The liver of a newborn is not mature for say up to 7 to 10 days after birth. Okay, so what happens is that there is increased production of bilirubin, but the liver is unable to conjugate and excrete it normally. Okay, because the liver is immature for about 7 to 10 days after birth, right? So there is increased bilirubin, but there is decreased conjugation. So we say that there is increased levels of bilirubin, leading to neonatal jaundice, right? Now this resolves by itself in say about 2 weeks, right? In about 10 to 14 days, because liver becomes mature, it comes to its normal level of functions in about 10 days after birth, and it conjugates all the bilirubin which is excreted, and the baby is fine. Okay, if it doesn't resolve on its own, there are certain things that we as doctors can do. So to prevent the occurrence of neonatal jaundice, we give phenobarbital. It is a drug Now how this acts is that it increases the activity of UDP glucuronil transferase. Now this is an enzyme. If you remember the conjugation of bilirubin, we said that bilirubin combines with UDP glucuronic acid and becomes conjugated to form bilirubin diglucuronide. Alright, we talked about this reaction in conjugation. The enzyme used here is this. So if the activity of this enzyme increases, the conjugation increases. The basic problem was that liver is immature, it cannot conjugate. So we have to increase the conjugation, which is done by this drug. This drug increases the activity of this enzyme, which increases conjugation. As we all know, conjugated bilirubin is soluble and easily excreted in the urine, right? So this is a preventive measure, phenobarbital. The treatment, if the baby is already suffering from neonatal jaundice, what we can do is expose the baby to blue light or UV light, ultraviolet light. Now what that does, it causes photoisomerization. That is, it changes the raised bilirubin into a compound called lumirubin, right? Bilirubin is converted to lumirubin, and that mechanism is photoisomerization. It is caused by exposure to UV light. Now the advantage here is that lumirubin is soluble. As we all know, increased RBC destruction will lead to unconjugated bilirubin rise, which is insoluble, right? So we have to make it soluble by converting it to lumirubin with the help of UV light or blue light, and this is easily excreted in the urine and the baby is fine. Now a concept called kernicterus. Kernicterus is a very dangerous and a lethal condition. It is seen when the serum bilirubin levels are above 20 milligram per deciliter. Now normally serum bilirubin levels are below 1 milligram per deciliter. If they increase above 20 milligrams per deciliter, what happens is that the bilirubin, let's come here, I'll show you here. This is, imagine this is the brain, okay, not actually a brain but still a brain for understanding purposes. And this here, for understanding purposes, we say this is the blood brain barrier, right, for understanding purposes only. This is a blood vessel, right, which is getting blood. Now normally bilirubin cannot go into the substance of the brain by crossing the blood brain barrier. The blood brain barrier prevents the bilirubin from entering from the blood into the brain. But whenever serum bilirubin levels are above 20 milligrams per deciliter, the levels of bilirubin are so high that the blood brain barrier cannot stop it from entering into the brain, and bilirubin enters into the brain and starts depositing. Now it deposits in one particular area of the brain known as basal ganglia. We'll study about this area in great detail when we come to neurology. For now, you just need to remember that bilirubin deposits into the basal ganglia, right, and causes its degeneration, and this condition is known as kernicterus, right? Icterus means jaundice, okay? Icterus means jaundice. So what happens is that whenever there is kernicterus, there is deposition of bilirubin into the basal ganglia, which is lethal. So that's it guys, that's all about jaundice. We've talked about jaundice in good detail. I hope you understood it. I hope I made it easy and it has gone into your heads, and now you can go back to your books and read it. It'll really be simple. You'll really enjoy reading jaundice. It's very interesting and it'll all make sense to you. That's what I hope. I'll see you in the next one.